Welcome to the Allergy and Asthma Network's 2016 webinar series. We have chosen the title Advances in Allergy and Asthma as we strive to bring you information on clinical issues, current treatment trends, and meaningful information on the daily management of issues related to allergies and asthma. My name is Sally Schessler. I'm the network's Director of Education. This month, we're addressing severe asthma concerns. Each month, we bring you nationally respected speakers to talk about issues that are important to you. Please plan to join us for each webinar in our series. For our November webinar, we're presenting severe asthma, evaluation, management, and new advances. It's my pleasure to introduce our speaker today. Dr. Bradley Chips received his medical degree from the University of Texas Medical Branch in Galveston in 1972. He was a pediatric resident for 2 years before serving in the Air Force at Ellsworth Air Force Base in South Dakota for 2 years as a general pediatrician. He then completed a combined allergy and pulmonary fellowship at Johns Hopkins and spent 1 year on the faculty in the Pediatric Respiratory Sciences Division. He has been in private practice in Sacramento since 1979. He is the medical director of respiratory therapy and the Cystic Fibrosis Center at Sutter Medical Center in Sacramento, California. He is also the associate medical director of the Sutter Community Hospital's sleep laboratory, which he established in 1984. He is board certified in pediatric pulmonology and allergy and clinical immunology. He is currently the vice president of the American College of Allergy, Asthma, and Immunology. We're so happy to have you with us today, Dr. Chips, and we're eager to hear what you have to say.
Thank you. I'm just having a little trouble getting the slides to advance, even though they were advancing a moment ago, so we're stand by one.
Okay, we'll stand by.
There. Okay, we got it now. So that's me. Thank you. And good afternoon, everyone. We're going to talk about severe asthma, some thoughts about evaluation, management, and new advances. So we want to understand what we're talking about first, the pathophysiology of asthma, look at the methods for asthma diagnosis, look at strategies that will help identify patients with asthma and how they will most favorably respond to the treatments that we have. Knowing we have a very diverse audience today, I will try to be basic, but also look for some more advanced ideas about how we take care of our patients. Knowing that the inflammatory disease is that we describe as asthma as a syndrome and not a specific disease, we have episodic and chronic airway symptoms with airway obstruction, bronchial hyperresponsiveness secondary to multiple triggers, partial or complete reversibility of airway obstruction. And we have to make sure, of course, we're dealing with the right diagnosis for the right patient. So, of course, the physical examination is important, pulmonary function tests, bronchoprovocation tests, and tests that tell us about the type and severity of airway inflammation, and also using validated control tools. This slide shows us on the left a flow volume loop where we measure relative flow rates over on the x-axis lung volume. On the right, we have a volume time plot, which is a spirogram. We use these modalities in order to help better understand the type and degree of lower airway involvement that is present in a patient. Looking at the top box, we are going to be particularly interested in FEV1, the amount of air that comes out in the first second in a forced expiratory maneuver, and also the ratio of FEV1 to forced vital capacity. In the patient that I show you here is a 24-year-old. The FEV1 is 2/3 of normal, and there is a very brisk bronchodilator response of 34%. So this patient had evidence of significant resting airway obstruction, and by relieving the bronchospasm, there then was a improvement in the FEV1 to 89%, which is within the normal range. The configuration of the spirogram on the right with a slow increase to FVC, which is forced vital capacity, or looking on the left, the bottom curve shows some what we call concavity toward the volume axis, or scooping of the flow volume loop. All of these are indicative when we look at these tracings to tell us that intrathoracic airway obstruction is present. But we know that these events are not static phenomena. And this is a combination of a study that I published 10 years ago in the Journal of Pediatrics, and Dr. William Calhoun is at University of Texas Medical Branch in Galveston published. My study was children, his in adults. What we did was to take the placebo group of three large inhaled steroid combination therapy trials, asking the question, if asthmatics are not treated with medication on a daily basis, controlled medication, how variable is their disease? And the children are in the orange bars, and you can see that 1/3 of both the adult and pediatric patients had 15 or more changes in their asthma severity based upon their peak flow during the 12 weeks of the study. So, very clearly, asthma is a highly variable disease. We can use a measurement of the degree of airway inflammation to help us. FeNO is a fraction of exhaled nitric oxide. Nitric oxide is produced in the alveolus and the airway wall by an inducible enzyme that then produces this in very small quantities. We measure nitric oxide in parts per billion. It is done with an expiratory maneuver that should last 6 seconds, but at a very slow rate at 50 milliliters per second. So this helps us diagnose steroid-responsive airway inflammation, support an asthma diagnosis when objective evidence is needed, and also help us identify the eosinophilic asthma phenotype. Looking at this particular slide, we're looking at 4 different pulmonary function measurements, as we just discussed: peak flow, FEV1, the degree of limitation of FEV1, how much FEV1 improves when steroid is used, and also the resting degree of inflammation. But what we could see in the slide is that the most sensitive markers to support a clinically suspected asthma diagnosis is the presence of eosinophil count in sputum, which is a very difficult test to do, of over 3%, or an exhaled nitric oxide that is elevated. This says over 20 parts per billion, but what is usually accepted now is 25 parts per billion. So then by doing this testing, we can determine the likelihood of a patient responding to anti-inflammatory agents, especially inhaled steroid. It will also help us at least have some directional signal about stepping down or stepping up medication, depending upon the patient's clinical condition. So again, adding more insight into how this test helps us in clinical practice. It will help predict response to glucocorticoid therapy. It also is very helpful in predicting the risk for exacerbation, which I'll show you in a moment, and it helps in managing asthma in terms of appropriate interventions to reduce the severity and likelihood of an exacerbation. On this slide, we can see that normal values are less than 25. Stable asthmatics generally are between 25 and 50. A value of over 50 in an adult or over 35 in a child or adolescent describes a group of patients who have eosinophilic airway inflammation and also who are more likely to respond to inhaled steroid therapy. As we measure asthma control, we have to look at a lot of different features, and it is very important that we take a very global and comprehensive view to what determines asthma control. Lung function and inflammation we've talked about. daytime symptoms, nighttime symptoms, very importantly, the use of quick reliever medication. The increased need to use short-acting beta agonists, that is using more than 4 puffs per week, describes a group of patients who have poor asthma control, and when one is needing to refill the 200-puff short-acting beta agonist canister more than 4 times in a 12-month period, it describes a group of patients who are at high risk for exacerbations and poor outcomes. We also have to then look at healthcare utilization and missing work or school. To do this, we need to have a validated control instrument. We are now very lucky in the United States to have, from age basically 6 months to octogenarians, the way to do it. The first tool is a track tool. We developed this tool in 2007 to 2009. There are 5 questions in this tool, 4 in the impairment domain, 1 in the risk domain. A score of 80 and above determines good control, 80 to 60, poor control, not well controlled, less than 60, very poorly controlled asthma. The minimal important difference is a movement of 10 or more. The Children's Asthma Control Test has 7 questions, 4 for the child, 3 for the caregiver. A score of 20 or higher indicates good control. A score of 15 or lower is very poorly, not well controlled asthma. And the minimum important difference is 3. Again, a scale of 0 to 27. The Asthma Control Test, like the Children's Asthma Control Test, has questions only in the impairment domain, and again, the score of 0 to 25 on this test. 20 and above is good control, less than 15 is very poorly controlled asthma, and with the Children's ACT, the minimal important difference is a movement of 3. This is a very important article that was published last year. Dr. Eric Bateman is a pulmonologist in Cape Town, South Africa, and a very prolific writer and very important contributor to our understanding. This very complicated slide basically looks at the determinants of airway obstruction as it relates to environmental exposures, the ontogeny of lung development, and genetic implications starting in utero and moving to old age. We're going to hone in on what happens in utero and in early childhood to understand that the die is cast for the severity of asthma starting in utero and especially in the first 6 years of life. You can see as we're looking at the risk factors for the fetus, smoking and biomass fuel in developing countries, because so many of these people have to cook inside with unvented open fires, nutrition, infection, smoking especially is important, use of recreational drugs, and intrauterine growth retardation all set the stage then as we move to the neonatal period, prematurity, low birth weight, children who required ventilation early in life, early viral infections, and environmental tobacco smoke exposure all lead then to early airway obstruction, that the same things continue to be present in childhood and the formative years up through puberty and beyond. Let's look now at, there are multiple studies that show the same signal. The Melbourne study now has 50 years of reporting. Here you can see that a group of patients were assembled from a birth cohort in Melbourne in the 60s. They were able to identify MWB, or patients who have wheezy bronchitis. The C are the controls, who have no respiratory disease. WB is wheezing bronchitis, basically wheezing associated with viral illnesses. A are patients who had clearly defined asthma. And you can see they start out with normal lung function. before 10 years of age, they've already had a dip. They realized early on they didn't have enough children with severe asthma. That group was added 10 years into the study. The point of this is the die is cast early. By the time these children can first do pulmonary function tests, they already have a significant decrement in their lung function. You can see between 7 and 10 years of age, and it continues pretty much unchecked through the rest of their life. So the die is cast early. The hit primarily associated with the early acquisition of an allergic diathesis or allergic predisposition and an intercurrent set of viral infections, usually rhinovirus, all lead then to persistent airway inflammation and persistent symptoms of asthma. So reduced airway function in early adulthood is associated with female gender, a history of early wheezing, having prenatal smoke exposure, having significant bronchial hyperresponsiveness, and this all correlates then with having current asthma. When seeing younger children in the office, even before they can do lung function tests, we can use some signals that help give us a predictive value whether or not patients are going to proceed to have more troublesome asthma. We have major criteria: a parental history of asthma, patient having atopic dermatitis, eczema, or having allergic sensitization to either house dust mite or a furry thing with a cold, wet nose. If you have one major criteria or two minor criteria, sensitization to egg, milk, or peanut, wheezing other than with a cold, or having bloody eosinophil count greater than 4%. If you have one major criteria or two minor criteria, you have a significantly higher chance of having asthma, like 6-fold chance of having asthma. If you have a negative asthma predictive index, you have less than a 10% chance of going on to have persistent asthma. But even taking this further, if we look at exhaled nitric oxide, which we just discussed a moment ago, at age 4, which we see on the x-axis, and the probability of wheezing on the y-axis, look at the huge differences here. If a patient has, on the top, an allergic mother having eczema, so already has 2 positive major predictive indexes, wheezing more than 4 times, and positive allergy tests, if the exhaled nitric oxide is above 30, there's an 80% chance that patient's still going to be wheezing. Alternatively, if none of the risk factors are present, no matter what his exhaled nitric oxide is at age 4, he has less than a 10% chance of wheezing. This helps us really understand that the processes start early, they're primarily driven by genetics and allergy, and are highly predictive of what's going to happen going forward. We know when we look at airway inflammation in asthma that we can see on the right-hand side that cells, macrophages, eosinophils, mast cells, and the release of cytokines, histamine, leukotrienes, all lead then to the end organ results that we see: bronchospasm, mucus production, a neural component with activation of afferent neurons, muscle constriction, muscle thickening and increased vascularity of muscle, permeability of vessels, and epithelial thickening. All these things lead then to the inflammation that we see in persistent asthma. As you can see, this is courtesy of Dr. Sally Winslow, University of Pittsburgh, Airway Research Center, the top being a normal biopsy of a peripheral airway. You can see a fatal asthma attack, quite tragically, but 10 people a day die from asthma in the United States. On the left, and chronic severe asthma on the right, you can see, without spending a lot of time going through each nuance, significant disruption of the normal airway architecture. So we have then smooth muscle dysfunction, we have airway inflammation, and we have changes in the airway. All these come together in this Venn diagram to give us in the pathophysiology of asthma and give us then direction about what needs to be treated in order to make things better. So looking then at the inflammatory milieu in the lower airway, it is very different asthmatic to asthmatic. That's why asthma is a syndrome and not a single disease. We'll talk about eosinophilic, neutrophilic, and polygranulocytic or polyimmune cell types. We know that in non-asthmatic controls versus proto-controlled asthma that we see a significant difference in both neutrophils and eosinophils in patients with not well-controlled asthma compared to patients without asthma. Both of these cell types can give us a signal about what treatments a patient is most likely to respond to. Neutrophilic asthma is clearly the most challenging asthma endotype that we take care of. It's consistently associated with corticosteroid use and low FEV1, usually less responsive to corticosteroid, more changes in the airway wall. There are more severe patients, poorly reversible, often of later onset adult asthma, especially in females who have elevated BMIs. And so Th2 being a more consistent inflammatory pattern seen more with allergic asthma is a concept that has evolved. Animal models have been used to study this. It is clearly being studied more now than Th1 asthma is, which is the neutrophilic, more the neutrophilic type I mentioned a moment ago. It's driven by multiple cytokines, IL-4, IL-5, and IL-13. This will be important in a moment when we talk about biologic therapy that can be used to help control asthmatics who are not responding to usual step care for medicines they can get from the retail pharmacy. So again, on the left, Th high and low asthma have decrements in lung function, bronchodilator responsiveness, and positive skin tests. But those who have primarily Th2 high inflammatory patterns have greater airway hyperreactivity, much higher IgE levels, and higher blood and BAL eosinophilia and exhaled nitric oxide. This is a very important study. Dr. Prescott Woodruff is a renowned asthma researcher at UCSF. He did a study, was published in 2009. He looked at different endotypes of asthma in patients who have high Th2 driven asthma, which means they have more positive skin tests, higher blood eosinophil counts, higher exhaled nitric oxide, greater bronchodilator responsiveness, and as you can see, more significant structural changes in their airway. These are the patients that respond to inhaled steroid. On the right-hand side, you can see what happens when the patients in this study were treated either with placebo in the black, no change in FEV1, patients with high eosinophilic Th2 inflammatory markers had a significant improvement in their FEV1 even after 8 weeks of therapy. At 8 weeks, the drug was stopped. They immediately returned to the baseline. The Th2 low had no response to very high dose inhaled steroid. And remember, on the average, between 40 and 50% of asthmatics do not respond to inhaled steroid, and it's important we do the appropriate diagnostic test to try to get a directional signal about who's going to respond and who's not going to. So we know many patients have been current or former cigarette smokers, and may have characteristics that overlap between COPD and asthma. On the left, asthmatic patients tend to have more eosinophils, mast cells, and CD4 positive lymphocytes. They have a high percentage of airway hyperreactivity and allergic disease, which is atopy, and steroids improve most of these patients, but not all. There are some that overlap. 20 to 30% of patients have components of COPD because of either occupational exposure to noxious fumes and irritants or cigarette smoking, and have a history of asthma before. They have the so-called ACOS or overlap syndrome. Contrast that to COPD, where primarily neutrophils, macrophages, mast cells, and CD8 lymphocytes are present in the inflammatory milieu. They have a slightly lower incidence of airway hyperreactivity, a clearly lower incidence of allergic disease, and our steroids appear to be not as effective in these groups of patients. This is the GINA step care chart. This is the European version of our U.S. guidelines, which were published 9 years ago. This particular guideline set is updated every year. We go from step 1 to step 5. Step 1 are patients who need a controller medication, who have fairly mild symptoms, and a low dose inhaled corticosteroid controls them very well. If they are moving to step 2. Step 1 patients are those who are usually managed with short-acting beta agonists on an as-needed basis. When symptoms are occurring more than 2 times per week, nighttime symptoms more than 2 times per month, they have evidence of resting airway obstruction, FEV1 less than 80%, or exhaled nitric oxide being elevated above 35 in a child, above 50 in an adult, then low-dose inhaled steroid is recommended. You can see that other alternatives are also given. When patients are not controlled there, then step 3 adds inhaled to the inhaled steroid, a long-acting beta agonist. Then we move up in dose, and we consider adding a long-acting antimuscarinic and also a biologic. So using this paradigm, let's now look at some data that helps support these recommendations. But what's very important to do is make sure the diagnosis is right, to make sure triggers are controlled, both allergic and non-allergic, to make sure inhaler technique and adherence is addressed very, very regularly at each visit, and make sure that alternative diagnoses are excluded and comorbidities are treated. All those are equally important as the pharmacologic strategy you use to treat the patient. So now let's look at what we might be doing going forward. We have a lot of new drugs. So on the y-axis we have either low going up to high eosinophil counts. On the x-axis we have low risk of exacerbations to high risk of exacerbations. For patients who have high eosinophil counts in their peripheral blood or high exhaled nitric oxide and a low risk of exacerbations, one can use just inhaled therapy with combination ICS, long-acting beta agonist, with without a long-acting antimuscarinic. If they, however, have a high risk of exacerbations, and this is where the biologics come into play, and we'll talk about that more in just a moment. In patients who have low eosinophil counts and low risk of exacerbations, inhaled steroid can be used regularly, or as I'll show you in a moment, in children on an intermittent basis. If they have low eosinophil counts, high risk of exacerbations, then again, ICS combination therapy with a long-acting beta agonist or antimuscarinic can be used, bronchial thermoplasty can be used, or we're in the process of developing new therapies at this time. Let's look now at some of the data that helps support these recommendations. The PEAK trial, which was published in 2006 in the New England Journal, was originally designed to see if early institution of inhaled steroid in children would prevent episodic wheezing to turn into persistent asthma. Again, asthma predictive index positive children 2 to 3 years of age. Half the group treated with Fluticasone 88 micrograms twice a day for 2 years, other half treated with placebo for 2 years, then 1 year of observation. Primary outcome, proportion of episode-free days. On the left, the 2 years of therapy. Fluticasone treatment in the blue, placebo in the red. You can see these patients, if not treated, had clearly more trouble. They had fewer episode-free days. But look very clearly where the dark line meets the light blue line, once the medicine is stopped, by 6 months later, everybody's right back to where they started. So there's no disease-modifying capability for using inhaled steroid, but if taken on a regular basis, it does control symptoms. But what's important to note is, who does it work for? And very clearly in this study, males who have a higher disease activity level in the pre-pubertal years were significantly different in their response than females. Caucasians had a higher response rate. Patients who had fewer episode-free days in the run-in period, i.e. they had a higher burden of disease, had a better response. Those who had been hospitalized had a better response, and those who already had at least one positive allergy skin test had a better response. So those asthma predictive index positive males with evidence of active allergic disease and disease activity were the ones who responded best to inhaled steroid. This again is seen looking at number of prednisolone bursts. You can see the males, Caucasians, patients with a history of hospitalization, ED visit, or positive skin test, all describe a group of patients more likely to respond. So again, those patients more likely to respond to Fluticasone as opposed to a leukotriene D4 receptor antagonist montelukast. Again, Fluticasone inhaled steroid, patients had a higher exhaled nitric oxide, higher blood eosinophil counts and IgE, more reactive airways, lower FEV1. The montelukast patients were younger, had shorter duration of disease, and had a high urinary LTE, had a higher leukotriene E presence in their urine. This is not a test you can get from your local lab. It's only a research tool. So, does everybody need everyday medicine if you're a child? And the answer is absolutely not. The MIST trial, 12-month trial, a double-blind, placebo-controlled trial. Children, you can see, between 12 and 53 months of age. They all had 4 episodes of wheezing. They all had a positive asthma predictive index. 1 episode at least required oral steroid, ED, or urgent care visit. The primary outcome was the number of patients who proceeded to need oral steroid. Again, these are intermittent, viral-induced young children. Simple study design, 52-week study. Half the patients took 0.5 milligrams of budesonide every night, and the other half took placebo each night. At the first sign of a viral respiratory illness, the placebo group took 1 milligram of budesonide morning and evening. The group taking budesonide every day had a placebo added in the morning. You can see the intermittent regimen in orange, the daily regimen in the blue. There's no difference in the number of prednisone courses needed. The time to first exacerbation is the same, and the frequency of respiratory tract illnesses is the same. And the time to first respiratory tract illness, again, no difference, no statistically significant difference, and no difference in height or weight. So in this group of patients who have viral-induced intermittent wheezing, you can use intermittent therapy. What if that doesn't work? What if you have to go to step 3 therapy? This is the Badger trial. This is 182 children, a crossover trial. Everybody got each of the 3 treatment strategies in 16-week blocks in a random way. Either low-dose inhaled steroid plus montelukast, low-dose inhaled steroid plus a long-acting beta agonist, or 2.5 times the dose of inhaled steroid. 3 outcomes: exacerbation, symptom-free days, and FEV1. Everybody had a good response to one of the drugs, but the best response was seen when long-acting beta agonist was added to inhaled corticosteroid. The ethnic differences very clearly in African Americans and the black population, they had a less significant response to montelukast. Otherwise, long-acting beta agonists seemed to act the best. And again, in stepwise comparisons, long-acting beta agonist plus ICS was favored in all of the comparisons that we see. We have a combination product that contains formoterol and budesonide. Formoterol is a very quick-acting, quick onset of action, long-acting beta agonist. It comes on with bronchodilator reversibility as quickly as albuterol does. So the question is whether giving the formoterol budesonide preparation twice a day, can you use it once a day and then step up if symptoms increase? A little bit of a complicated slide, but visually tells you the story. The top is 4 times budesonide given twice a day with terbutaline as needed. The second is budesonide formoterol given twice a day, terbutaline as needed. The bottom, budesonide formoterol given once a day and a second dose later in the day if needed. You can see that paradigm had the lowest rate of exacerbations. What does this tell you? It tells you that the early use of a bronchodilator with an inhaled steroid when loss of control is present leads to better outcomes. A very important observation. This, you can see, are 6 studies that look at the same outcome. The red bar is a bar to look at. That's fixed and reliever therapy. And I think this, I know this is applied all across the world. It's not currently FDA approved, but it's something many of us do every day in our practice. So what happens now if you're not responding to ICS, long-acting bronchodilator? What do we do next? Well, you can add tiotropium. This is a complicated slide, but what it tells us is if we add tiotropium to ICS LABA, we can get, the top line is adding tiotropium, the dotted line is adding placebo to ICS LABA, and we can see improvement in FEV1 in both trials and an improvement in time to first exacerbation. So long-acting antimuscarinics are now approved in the United States for the concomitant treatment of patients with asthma in addition to COPD. But no matter what we're talking about, these drugs do not give complete relief. This is a study I've been involved with for the last 16 years. We're looking at 1,261 children with significant asthma. We're asking the question, does it matter what controller therapy I give them from the pharmacy? Does that control their asthma? Left, patients ages 6 to 11, the right, 12 to 17. Yellow, 1 controller. The teal, 2 controllers. The red, 3 controllers. There's very little difference no matter what outcome you look at. Look at ever intubated. Up to 15% have been intubated. The bottom 2, corticosteroid burst over the last 3 months, unscheduled office visit. Didn't matter what we gave these patients, good control did not result. Therefore, we've got to look at what are the next steps. The biologics are emerging players in the asthma market where we're trying to block mediators that cause airway inflammation and bronchial hyperreactivity. We're going to look at then several of these molecules going forward to try to understand how we can interrupt the Th2 high inflammatory process and lead to good relief. We'll first look at anti-IgE. It's been on the market for the longest period of time. This is the ICATA study. You can see 419 patients from inner-city asthmatics, children about 11 years of age, 7 years of duration of their asthma, lung function still preserved at 92%, 73% had moderate to severe disease. They were either treated with placebo or weight and IgE-appropriate doses of omalizumab for 60 weeks. There was an improvement in the top line in days with symptoms with omalizumab, decrease in exacerbations, and decreased need for oral inhaled steroid. But the most important graph is the next one. And look at the middle bar. This is now looking at the data over time, looking at spring exacerbations and then fall exacerbations. Week 38 of the year in North America is when the fall illness season begins. Omalizumab thought at first to be just a drug that helped allergic asthma also dramatically decreased fall exacerbations of asthma. This was a huge wake-up call. This opened a whole new set of understandings about how well this drug can work. So we know omalizumab responds more efficiently in patients who have high levels of exhaled nitric oxide and high peripheral eosinophil counts. This caused then the NHLBI network to look at pretreatment before the fall illness season to see if children could be pretreated. Week 38 is when the fall season starts, starting at week 32, and prevent exacerbations. One group had standard care, one group had high-dose inhaled steroid, the other group had standard care plus omalizumab. And again, there was a much greater effect in those patients who had an exacerbation during the run-in period and little benefit from dramatically increasing the dose of inhaled steroid. Here we're looking at proportion of patients who had at least one exacerbation. Patients on step 2 to 5 care, there was a difference, a reduction, but the greatest reduction was seen in the patients who required the highest baseline therapy and who had had an exacerbation during the run-in period. And that's what we see in the top bar here. Exacerbation during the run-in period at step 2 to 5 care, and then at step 5 care on the right, again, a dramatic decrease in the number of exacerbations. And that was particularly seen in those patients who, when their peripheral blood monocytes were challenged with rhinovirus, those patients who had on omalizumab, who had who during that study period had a greater increase in interferon when their peripheral blood monocytes were challenged with rhinovirus, had a much lower chance of exacerbation. In the U.S. market now, we have IL-5 inhibitors, which have been released this year. We have mepolizumab and resilizumab are currently available. Benlarizumab is still in development. We know that, I told you a moment ago, that patients who have the highest exhaled nitric oxide levels, as you can see in this graph from the NHADE study, associated with very high blood eosinophils, greater than 400 in the orange line, no matter what you look at, probability of current asthma, probability of current wheeze, ER visits, or asthma attacks, as the exhaled nitric oxide goes up and the blood eosinophil count is elevated, their burden of illness and exacerbation goes up dramatically. This is also shown in a large 125,000 patient cohort that David Price reported late last year. As the peripheral blood eosinophil count increases, the chance of exacerbation goes up dramatically. And in this study, just look at the far right. Patients who have blood eosinophil counts greater than 400, sputum eosinophils greater than 3%, and an exhaled nitric oxide over 50, they have a 3.7 increased risk of having an exacerbation compared to those on the left who have low eosinophil counts and low nitric oxide. And this is in the face of taking high-dose inhaled steroid and long-acting beta agonists. The anti-IL-5 drugs work to decrease airway inflammation by a different mechanism. Benlarizumab will work for programmed cell death for eosinophils. The two that are currently on the U.S. market work by tying up or blocking anti-IL-5. Mepolizumab is available in the U.S. market. It has been studied in multiple trials. I just want to show you one trial, again, of a group of patients who have a very rich eosinophil signal, exhaled nitric oxide greater than 50, blood eosinophils greater than 300, more than 2 exacerbations in the year. Just look at the top left. These are the cumulative index of asthma exacerbation over 32 weeks. Placebo patients in the top, patients treated with mepolizumab on the bottom, a significant decrease in exacerbations and a small increase in FEV1, but no change in their exhaled nitric oxide. Reslizumab, again, is an IV preparation. Mepolizumab is given subcutaneously, as is omalizumab. It reduces sputum eosinophil counts, improves FEV1, and improves quality of life. It also significantly decreases exacerbations, as you can see on the left, and improves FEV1, as you can see on the right. Benlorizumab is not available yet in the U.S. market. It will work on eosinophilic airway inflammation in a different way by tying up the IL-5 RA ligand receptor and causing them ADCC, which is cell death of the eosinophils, decreasing airway inflammation by that mechanism. We know if you look at on the right-hand side, benlorizumab, as the eosinophil count increases, the dose of benlorizumab has a dramatic improvement, almost a 70% decrease in the amount of exacerbations that are present on the one-year follow-up. But remember, this drug is not yet available in the U.S. market. Other biologics that are in the pipeline include dupilumab, which is an IL-4/13 inhibitor, and also the IL-13 inhibitors, lebrikizumab and tralokinumab. Dupilumab is, again, you can see in this one study, had an 87% reduction in exacerbations compared to placebo. It is, and also in the high eosinophil-rich population, a very quick improvement in FEV1 at all the doses you can see. It is likely that the 200 milligram dose every 2 weeks will be the dose that's going to be used, and you can see then that there is a 64 to 75% reduction in exacerbations. This is a drug that is likely to be given by injection every 2 weeks at home. The anti-IL-13s, again, are in development. Lebrikizumab, as you can see in this slide, is the development phase has been stopped with this drug. I show it to you because it's in the peer-reviewed literature, but it's not being brought forward for asthma at this time. So we can see then in summary that multiple cytokines drive airway hyperreactivity, mucus hypersecretion, eosinophilic airway inflammation, and IgE production, both in the acute phase on the left and the chronic phase on the right. In addition to these things, we have goblet cell metaplasia, smooth muscle hypertrophy, epithelial changes, and fibrosis and remodeling. So guideline treatment is not optimal in at least 50% of patients. Step 3 and above, step care, requires assessment of the role of the Th2 mechanism to guide therapy. We have to recognize and treat comorbidities. Long-acting antimuscarinics may be helpful at step 4. Biologics are currently directed only at Th2 pathways, but we have to move ahead to find a better way forward for non-Th2 asthma. Macrolides may help reduce exacerbations in non-eosinophilic asthma as they do in COPD. They often may still be of some help in current or former smokers, and the role of bronchial thermoplasty continues to evolve in our management of patients with non-Th2 mediated asthma that have significant bronchial hyperreactivity, recurrent episodes of wheezing, and are not cared for well with the current drugs that we have. Let me thank you now and see if there are any questions.
There are a few questions, Dr. Chips, but thank you so much for that great information. So one question that came from one of our listeners, they'd like to know what the role of roflumilast is in asthma and ACOS.
Roflumilast, phosphodiesterase inhibitor, has had limited uptake in asthma. Dr. Eric Bateman, who one of the articles I showed you earlier, presented a combination roflumilast montelukast add-on strategy to patients not responding to long-acting beta agonists and ICS, primarily being directed to a population in underdeveloped countries where the biologics are not possible because of their expense. He was able to show a modest improvement in outcomes when it was added to combination therapy, but not as dramatic as the biologics. So the answer to your question is there is a role, but remember, Apremilast can have a 25% increased incidence of headaches and GI symptoms. So we have to up-titrate the dose to make sure we can get patients to the 500 microgram dose once a day as soon as possible.
Okay, another question asked, in the Badger study, do the relatively high p-values mean that some of the data is significant but just needs a lot more study?
I'm sorry, that some data is significant, but what?
The question was, do the relatively high p-values, being that, it's at IEP at 0.05, mean that some of the data is significant but just needs a lot more study?
Yes, but again, all but 4% of the patients had a response to something. But we're just showing you that there are certain factors that predict a long-acting beta agonist, which is the most predictable add-on to ICS for response.
Okay, our next question is there any information available on preventing airway remodeling?
It is quite meager. It's very clear that inhaled corticosteroid does not have a predictable effect upon structural changes in the airway. There's a study with omalizumab that Rako Drakonovich published, a biopsy study showing that not in every patient, but in a majority of patients, that inflammatory and structural changes in the airway could be positively affected with 6 months of therapy with omalizumab. There are also ongoing studies with the 2 anti-IL-5s, and there will be studies, I'm sure, with the other biologics. I think the chances of seeing important regression of inflammatory and structural changes in the lower airway will be very high with these biologics.
Okay, we have time for one last question. The question is, a recent report indicated higher hospitalization rates for COPD patients with asthma. Would you recommend any different therapy for COPD with asthma than those without the asthmatic component?
Yes, the ones that have the ACOS syndrome with a history of asthma, and that's better defined with an antecedent history of an asthma diagnosis, are having a bronchodilator response of greater than 400 milliliters to short-acting beta agonists, and also concurrently having an elevated IgE and positive allergy skin test. In those patients, then inhaled corticosteroid in addition to a long-acting beta agonist with or without a long-acting antimuscarinic is the treatment of choice. And in fact, in a recent paper published in Chest, patients who had the ACOS syndrome with an asthmatic component had better outcomes than those who didn't. And so that's actually very encouraging.
Okay, well, thank you so much today, Dr. Chips. You really provided us with just a wealth of great information. And it was important, I think, that you noted that 10 people still tragically die every day from asthma. So there's a lot of work for us all to be doing. So thank you again, Dr. Chips, and I'd like to remind our listeners to be sure and register and join us for the remaining webinars in our series. Our December webinar will be on smoking and asthma and will be presented by Dr. Michael Blaze. Watch for registration information on our website. Go to allergyasthmanetwork.org, click on Education, and then Webinars to register. But then also you'll find all of our recorded webinars, and this webinar is also being recorded. So our webinar series helps the Allergy and Asthma Network to live out our mission to end needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. So as we conclude today, please access the Allergy and Asthma Network's website for valuable information with sections designed for both patients and healthcare professionals. This webinar will be posted this week in our education section. Again, look for the education page and then click on webinars. On behalf of the Allergy and Asthma Network, this is Sally Schessler, Director of Education. Thanks for joining us today.